So I'd like to switch gears now and introduce Dr. Patrick Flume. Dr. Flume is the CF Center Director at Medical University of South Carolina. He is an adult pediatric pulmonologist and intensivist and has been at the forefront of clinical research in cystic fibrosis for many years and has been the champion of a number of clinical trials. So he's going to talk to about, we have modulators, now what? And I would encourage people to put your questions in the chat and we'll answer them at the end of the talk. So thank you for joining us, Patrick.
Good morning, everybody. Thank you, Peter. So I was asked just to give a little presentation on where we are with research, and there have been a lot of changes that happened in the last year, some of which have already been discussed, and how we think about this. And so when we talk about research, there's a lot of different areas that one can think about. So obviously there's the basic sciences or discovery research. So looking at how things work or what happens when they're not working. And that's necessary for us to develop novel therapeutics. So we're talking about drugs here that, like the modulators to basically come and try to make things better. But we also do research in diagnostics. How do we improve our ability to know what's going on with our patients? Other things that tell us what the future might be, these prognostic markers, trying to predict outcomes, who is going to have more progressive disease versus those who are not, their disease status is gonna be relatively mild. And outcome measures, on the surface, this may seem pretty obvious, but it's not as easy as one thinks when you're doing drug development. So an outcome, a person dies, that is a clear outcome, it's a bad outcome. But changes in lung function, changes in symptoms, and the onus is upon us to try and be able to convince the regulatory agencies that we are able to measure changes, that things improve, and that the measures are reliable, so they feel confident that the therapy is improving the outcomes in that particular patient. There can be research related to better treatment practices. I'm going to talk about some of those as well today. And then there's quality improvement, which may not be research in the pure sense. You may not be randomizing and comparing things, but you are doing something in a rigorous manner that allows you to try and improve the evidence base so we have greater confidence in what might be best practices. Now, in my role as editor for the Journal of CF, and then of course we just had our CF meeting, you all know that CF affects all different parts of the body. It's not just about the lung, and there is ongoing activity in all of these areas. But we don't have time to go over all of these areas. I will tell you that one of the plenary sessions at the North American meeting this last month was dedicated to gastroenterology. So the foundation and the community have recognized that there are other areas that we need to be better in, such as endocrinology and the GI system. So let's start talking about novel therapeutics and where we are in terms of drug development, obviously now that we have Trikafta. And Trikafta is primarily targeting lung disease. And so just briefly to go over the pathophysiology of lung disease, we start with gene mutations, and this gene is coding for the CF proteins, what we call CFTR. You either get a reduction in the quantity or how well it works, and the end result is you get a reduction in the airway surface liquid. There are other properties that are abnormal, but in general, think of it as that fluid layer on top of the airways is too shallow, so the cilia can't do what they're supposed to do. That results in an impairment in their task, which is to clear stuff out of the lungs, and renders the airways vulnerable to obstruction, that these secretions, this mucus starts to plug off those airways. It makes them vulnerable to infection. That infection persists. These bacteria have a way of making a home down there. And then the body responds with inflammation. And it's the combination of these things which is causing damage to the lung. And as the lung is progressively damaged, that's what leads towards respiratory failure. And then if you look at the model of that pathophysiology, and on the right side, looking at the success that we've seen over the last several decades in terms of survival, you can see where these therapies have come into play. And so, for example, Dornase alpha was our first drug that was developed for the treatment of CF lung disease, and that was in the early 90s. So we're actually approaching 3 decades of Dornase use. Then antibiotics. I don't mean antibiotics in general. There were always development of antibiotics, and for example, the development of ciprofloxacin was a major benefit in the CF community for treatment of taking the drug systemically. Here I'm talking about inhaled antibiotics, and so tobramycin also was developed in the 90s, and then later we had aztreonam. Hypertonic saline was not really a novel therapy as much as a practical approach to trying to treat the airways disease. That came out. People began to look at ibuprofen and macrolides. We think of these as dealing with inflammation, but we recognize that they're not overly potent as an anti-inflammatory. And the macrolides, although they do have anti-inflammatory properties, they are antibiotics, and so we can debate about their role. But the key here is I want you to notice that as these therapies were added to the regimen and we were seeing continued improvement in survival, all of these were targeting the downstream consequences of CF disease. They weren't addressing the basic underlying problem, and that's where the modulators came into play. So with ivacaftor, which potentiated that channel, if the channel was present in the airway surface, it could kick it up a notch, and it was highly successful and really motivated us to think and to know that these small molecules could actually result in improvement. And then since that time, we've had rapid development of these correctors, initially with lumacaftor in combination with ivacaftor, then tezacaftor, alexacaftor. And Trikafta is the combination of alexacaftor, tezacaftor, and ivacaftor. So that's where we are. We've been marching along. And the thing about research is that as soon as you finish a study and you're looking at your results, it should be spurring more questions. You're not done. You're never really finished. And so those next questions, some are obvious. Does Trikafta work in younger patients? So the Trikafta study was done in 12 years and older. What about those that are younger? And our goal in development of CF therapies is we want effective therapy for everybody. And when you're talking about CFTR modulators, where you're treating these upstream effects, trying to get closer to the basic defect to try to prevent the development of those downstream consequences, then obviously you might want to begin treating as soon as possible. And that could be even from the time of diagnosis. And so you've got to think about how you develop these therapies. And to give you an idea of the approach that has taken place for development of these modulators in younger age groups, you can see ivacaftor was approved for ages 12 and up in January of 2012, and then was approved for 6 to 11 years, just a little more than a year later. That's very fast in the development of drugs. And then now has been approved down to age 6 months. And you can see where we are with the other products in terms of the dual therapies or the triple therapy. And I think that we finished enrollment in the 6 to 11 year age group. So there is a goal towards moving in the younger patient populations. But there are challenges in doing trials in children. Number one, the endpoint that you are interested in may not be measurable. And so, for example, if we're looking at changes in lung function to get the approval for Trikafta, well, if you're looking at an age group that can't perform spirometry, so the very young, and even though we can do infant spirometry, it's not a standard approach to testing among centers. So it's difficult in that group. And then you have the challenge of these these kids are generally healthier, and so their lung function is typically better, and it may not be as responsive to change with these medications. But the FDA provides guidance for that. Now, first off, they require these sponsors to have a pediatric plan when they're coming forward with a product to be approved for adults if they believe it's likely to be used in the pediatric population. And obviously, if we're going to use Trikafta in the adults, they know we're going to want to use it in kids, and so they want to know what that pediatric plan would be. They do allow you to extrapolate the benefit that you found in the adults to the pediatric patients when the clinical indication is the same. Clearly, that's the case in cystic fibrosis, and when the outcome of the treatment is likely to be similar. So in this case, you're not going to show that there's an improvement in lung function, but there are some other measures that can be used to meet that goal. They do not require you to use a placebo, and that creates some interesting challenges when you begin to analyze it. And they want you to focus on what we call pharmacokinetics. And essentially what this is how does your body handle the drug? So does a child need the same dose that an adult needs, or does it need to be adjusted for some reason? For example, their weight. And so we have to measure that carefully to know what the dosing requirements would be. And of course, we have to look at safety issues. So even though they don't require efficacy data, the CFTR modulator studies actually show a reduction in sweat chloride. So what we can see in the children is actually quite similar to what we see in the adults. So it demonstrates that it's got a similar effect. Although you may not see an improvement in FEV1, there is another measure of lung function we call the lung clearance index. It's an old test that has found a new life in our clinics, in our research areas in particular, in which a child can just breathe regularly through the device. They don't have to do any special maneuvers, and we can look at how rapidly a marker gets cleared out of their lungs. And so if there's no air trapping, then that measure would be improved. And then there might be other measures that can suggest benefit. And so what has been shown in kids with these modulators is actually an increase in fecal elastase. This is a pancreatic enzyme. So although we think of these children as being pancreatic deficient and in need of taking digestive enzymes, they may not be completely, and there might be some added benefit in organs other than the lungs. Adverse events, normally I describe adverse events as, it's just counting beans. You're just asking if there's any problem and writing it down. But remember, there's no comparator. You can't collect these numbers and then say, well, this is how the drug compared to a placebo. So in kids, growth and development is very important, but if that's the factor you're going to be looking at, it's really hard to know if it's affected in a very short-term study. And then respiratory events may be hard to detect because the child may not complain. And so Lumacaftor, which was the first corrector that had been approved, had an unfortunate side effect of causing bronchospasm or chest tightness. And so in the adult or adolescent population, they could describe this chest discomfort or shortness of breath. The child may not complain of that. And so you have to look for features like, do they increase their breathing? Does that really mean that they're having a respiratory event? And then the other adverse event of interest in the modulators is the effect on the liver, causing elevation of liver function tests. And so though this may seem pretty straightforward, you just measure the blood and they're looking for how the value relates to normal. And typically they'll say that anything that's 3 times normal is abnormal. What you find when you start doing this in these kids is you start finding elevations of the liver enzymes. So you stop the drug, the liver enzymes come down, you restart the drug, there is no change in the liver enzymes. So you're left thinking, well, was that the drug that did that? Or is there some variation that occurs in these kids? And honestly, does it occur in any child? Is it something unique to cystic fibrosis? Or is that something that children get because they're exposed to viruses that might cause their liver test to go up? And frankly, we don't have good data on any variation in liver function testing over time in children. And that's a gap that needs to be filled. All right, so pushing for the pediatric patients, and there actually was a pro-con debate at the meeting about whether we should be using these expensive drugs in these healthy children, but I'm not going to go into that. What about other modulators? Are there other modulators that might be better and for that matter, safer or easier to take? Now, we all already know that the modulators, you've got ivacaftor, which works by one way. It's kicking up that protein to work more effectively. It's a potentiator. The other modulators, we call them correctors. They help to traffic the protein from where it's made all the way up to the cell surface. And so they work in different spots. Now, lumacaftor and tezacaftor were the first two that were approved. From an efficacy standpoint, in terms of how well they work, they're probably about the same. But there clearly was a greater safety benefit in the tezacaftor group. It did not interact with other drugs like lumacaftor did. It did not have the chest tightness. So that's just an example of how you might find a modulator that is better. Alexacaftor is more potent, but we're using it in combination with tezacaftor. So what I'm showing here is the way that the CF Foundation sort of demonstrates the pipeline in terms of what drugs are in development and how far along are they. And so when you have a molecule that you think would have some benefit as a drug, there are things that you have to do to prepare that for testing. And that's what happens in the preclinical. So you're doing testing in the laboratory with cell models or with animal models to try and demonstrate what it looks like if it's doing what you want it to do, as well as trying to get some clues as to safety issues that you might want to pay attention to. And then when you enter human trials, you go into what we call phase 1, which is entirely about safety. And in generally starts with healthy controls. They don't have the condition, then moving into people that have the condition. And what you're trying to do is just to make sure that there's safety and get a handle on what kind of dosing that you're going to do. And then you move into phase 2 and 3, always are concerned about safety. So safety is always being tracked in all of these. Phase 3 studies are your definitive trials that you intend to take those results to the regulatory bodies to say, my drug works and it's safe, I want you to approve my drug. So what happens during phase 2 is trying to design studies that help you inform what those phase 3 studies will look like. What are the kinds of, who are the patients I want to enroll? Who are the patients I should not enroll? How long should I do the study? What outcome measures are of interest? And so what you can see here is a number of companies that are still in the process of developing CFTR modulators. You can see AbbVie, they have similar potentiator and corrector that they're into phase 2, looking at combinations for Delta F508. Elox is looking at those subjects that have stop mutations or premature stop codons to try and develop a read-through so they can actually get a full copy of the gene to express protein. Proteostasis has 3 different products, one of which is novel, this amplifier. I'll talk about that in a moment. And then Vertex also has other drugs they're beginning to develop. So the trying to improve upon the modulator activity. What are the other benefits of CFTR modulators? And this is getting at things that are outside the lung. The drug was approved because of benefits in FEV1, but also there were other benefits. Reduction in pulmonary exacerbations was a key issue for the FDA in terms of their approval. And then with the modulators, you really want the drug to modify disease. Yes, it's great that you want FEV1 to go up, but if you really want to modify disease, you want to stop it from going down. you're trying to change the rate of loss of lung function. And so using data from our registry, it has been shown with ivacaftor and the combination of lumacaftor, ivacaftor, or Cambi, and then most recently accepted for publication is the same result for Teziva or Symdeko, that shows that you do in fact see a slowing in the rate of loss of lung function. It does not go to zero, but it's about a 60% reduction in the loss of lung function. Think of that like compound interest. That pays dividends downstream. So when I think of that kind of improvement in the lung function, I think that in the terms of time. You also will have seen the data showed improvement in quality of life scores. Actually, there was improvement in weight gain. This is actually becoming a potential issue for some patients because some patients have had excessive weight gain. And so this has resulted in some dynamic changes in how we counsel our patients with a focus on body image. And our goal is not to create an overweight and obese CF population. It's to just keep focusing on a healthy CF population. We have seen reductions in sinus complications. There is some potential benefit on the diabetes side. And then just a comment on female fertility. We seem to have had a bit of a baby boom after the release of Trikafta. I think our center alone is somewhere around 9 or 10 pregnancies. The fertility issues in males is an obstruction of their vas deferens. That's the duct by which sperm can get out, and that's generally blocked. And we don't really anticipate an improvement in fertility in the adult males with this. Maybe we could if we're treating young male infants. But the fertility issues in females, it has long been taught that they have a reduced fertility, and the mechanism is essentially obstruction, that the mucus on the cervix is not normal and it causes a mechanical barrier. And so now if you fix that, you put someone on a modulator and now things start to improve there, you may have solved some of the fertility issues. And we saw some of this in the trials of Orkambi and Symdeko, but it was really remarkable after the release of Trikafta. What we do not know is the risk benefit of remaining on Trikafta or any of the modulators while pregnant or while breastfeeding. The animal studies would suggest that things are probably okay, but there have been no human trials to be able to counsel our female patients. But the CF Foundation and our therapeutic development network had been prepared for this, just like we had done with ivacaftor, to begin tracking these other additional benefits in people who are started on Trikafta. And so what you can see here are a number of studies looking at other effects in the airway, the GI tract, with diabetes, with bone health, in people who are being started on that. And what is really encouraging is that you see that this target enrollment, essentially all of these filled very rapidly. I don't remember exactly when these were filled, but remember the drug was released last October. And for this many patients, subjects to be enrolled in every study, it's really, truly remarkable. So that's really a great example of the enthusiasm that our CF patients have with participating in clinical research. But what about those patients who can't take Trikafta? And so this includes those, ignoring the younger patients, those patients who don't have a copy of Delta F508, or even those who have an adverse reaction to the drug combination. And keep in mind that there is no drug out there that is free of baggage. Every drug has the potential of some side effect. Some of those side effects are relatively common, and we know what to look for, and some are going to be uncommon. So there have been patients who started on Trikafta who have already stopped the drug. And so they are looking for other options as well, because in many cases, they appreciated the benefit from the pulmonary aspect, but had to stop it because of other issues. So our approach to trying to fix CFTR activity, remember the mutation might result in an abnormal function. So in this case, you can see at the top of the cell, the protein is present, but perhaps it's not working well. And that's where the potentiators come into play. So increasing the opening time of that protein so stuff can flow through it, or even making sure that that protein stays up there longer. The correctors, they help solve the issue of getting protein from where it's made to get it up to the top of the cell. So it has to go through a folding process and then some processing and trafficking to get it up there. And that's where these correctors are being used. But then there might be other methods of trying to increase the amount of immature protein. And there are a number of strategies which have been described. Early on, after we discovered the gene, there was a lot of interest in gene therapy. There was a great promise that we would be replacing the gene. Obviously, that has not come to fruition. We've learned a lot about how difficult it is to try and replace that gene. Doesn't mean it can't happen, but right now it's not ready for prime time. One that is getting a lot of press is DNA editing, that perhaps we could go in to the gene and actually fix it. You'll hear about techniques like CRISPR as a means of doing that. There are still a lot of hurdles that have to be overcome. It's attractive to what can be done in the laboratory, but just recently there was a journal article using the CRISPR technique to try and fix a gene that causes blindness in children. And there were some errors in terms of the editing. So those issues have to be resolved before we'll really get into human trials. Then there's editing of messenger RNA. So when you make a copy of your gene, of the DNA, the messenger RNA is what's used as the instructions for to make the protein. So if we could edit it there, maybe that would be a strategy. I told you about the ELOCs, the read-through of premature stop codons. Every gene has a period at the end of the sentence that says stop copying here. And if a mutation makes it seem like there's a period occurring earlier, what you end up with is just this nonsense. It doesn't have a full protein. So if we could have a molecule that would allow us to read through that, to recognize that that's not the true stopping point. And then the amplifiers are another interesting product that what they do is they increase the translation. What that is that when you have message and the ribosome, it binds onto the message and it begins to read it. And as it's reading it, it's knitting together the protein. Think of it like putting beads on a string. So it's just adding those beads and then you end up with full protein. But a key aspect of this is as this protein is coming out of the ribosome, it needs to bind to endoplasm. It needs to bind to membrane, and that anchors it so that it can begin its folding process. That turns out to be a rather inefficient step. And what the amplifiers do is actually make that more efficient. And so what you get is longer lasting message, but more importantly, more copies. And so you get more copies of protein. For some mutations, that's just what you need. You can get more protein, it'll get all the way up there. Maybe you create more substrate for the correctors to work on. It's an interesting approach to trying to solve that quantity issue. There are a number of products that are in development here. I told you about the proteostasis. That's an amplifier that they're looking at. And there's a number of companies working on these other technologies, but you can see they're all still in preclinical. They're not ready for human trials at this point. So then you can ask, well, now that I've got Trikafta, what is the value of these other downstream therapies? The Dornase, the inhaled antibiotics, hypertonic saline, the macrolides. Well, keep in mind that there are still patients who don't have access to modulators, so they might be people that would benefit from these therapies. And then those people who have, disease, structural disease, bronchiectasis, that's not going to go away. So they may still have improvement, a reduction in their cough and sputum, improvement in their lung function, but their airways are still abnormal. They're still going to have some abnormal mucosal clearance and persistence in their infection. And so we can begin to ask, well, what is the benefit of these therapies? And so there are still drugs in the pipeline to try and create opportunities or options for our patients. So on the airway clearance side, you see this inhaled mannitol. This actually was just approved by the FDA last week. Mannitol is a dry product, sugar alcohol, that you all have had mannitol if you ever chewed any sugarless gum. And uses a dry powder into the lungs. It's intended to try and enhance mucociliary clearance and clearance of these secretions. So think of it like you think of hypertonic saline. So what this may well do is give people an option. Would you rather do it a dry powder or a wet nebulizer if you believe that those therapies are effective? There are other products that have tried to target other channels to try and bypass the CFTR effect. The Boehringer product was just halted. They didn't feel like it was doing well enough. These others are still in early stages of development. On the inflammation side, there are some novel approaches to this. The history of development of anti-inflammatories has been challenging because on the one hand, inflammation is good. And so you don't want to necessarily block it out completely because you need it to combat infection or other injury. So if they used an anti-inflammatory that was too potent, that actually created new problems. And so this linabacim is an interesting product. This is actually a derivative of THC, which is in marijuana. And what it does is it has an interesting effect on inflammation. When you have an injury or an infection, you want your inflammation pathways to kick in and do their thing. But at some point, you want it to go away. You want it to resolve. And so what linabacim does is it actually enhances that resolution side. And the inflammatory effect of in CF is exaggerated. And so in a phase 2 study that was done, there actually showed a hint that it was reducing exacerbations. And so a phase 3 study was done, which was just presented at the CF meeting, and unfortunately did not hit its primary endpoint. And that creates a problem in terms of advancing it further. If you don't hit your target, the FDA doesn't usually look too fondly at it. There were some challenges to the way the study was conducted. So I'm not sure that product is going to go away. There might still be some future for it. The Laurent product is a vitamin A, also to try to enhance anti-inflammatory effects, and there are others that are in development. And then from the antibiotic standpoint, inhaled levofloxacin is actually approved for use in Europe and other countries, but never came forward to try to get approval in the FDA, and that's a more political issue. So it's not available in the US. Our targets approaching Pseudomonas have then had us look for other things like gallium, and so IV gallium has been studied, seems to have some potential effect, maybe even as an anti-inflammatory. It's a bit inconvenient, and that's why you see an approach here with an inhaled gallium. But there are other bugs that we deal with. It's not just Pseudomonas. There's staph, so especially with methicillin resistant. And so vancomycin inhalation powder, or Arovanc, has completed studies and is nearly ready to see the data. So we're all hopeful that we get some positive results, but that remains to be seen. And then novel agents like nitric oxide. So using a gas to try and kill bacteria. This study also has been completed, and the results have not been revealed as of yet to see if it had any beneficial effect. It was used much like you would use Toby or Caistin to try and see if there's an increase in lung function in the short term. But we've actually used this in a study against mycobacterial lung disease and are thinking that there might be some future in that area. And as you all know, the CF Foundation has made considerable investment in the anti-infective space. I want to move on to talking about treatment practices, because this is a different sort of target of approach in terms of how we think of things. Again, going back to what's the value of these other downstream therapies, And I put now here is the first bullet. Now that people are feeling better, I'm not coughing anymore, I'm not producing sputum, do I really need to do these other treatments because they create burden and they'd like to reduce that? Again, this was anticipated, but it's hard to advise people to say, yeah, if you can stop your hypertonic saline or stop this other drug and it won't matter, but we don't know that. And the best way to know that is to do a withdrawal study. And so the TDN designed the Simplify study using a reduction of stopping hypertonic saline or Dornase to see if there's any immediate safety issues, that, loss of lung function. And you can see that it's essentially a short trial, 6 weeks, to try and test that. There was discomfort about stopping the inhaled antibiotics because the bugs might be persistent, but so that's the strategy to start. I want to move on to pulmonary exacerbations. These are events in which there is worse symptoms, increasing cough, increasing sputum, maybe loss of lung function, loss of weight. These are frequent events. And when we did our guidelines years ago, what we realized is there wasn't a lot of evidence to support what we did. And it's not that we didn't know what we were doing or how to do it, but we didn't have any evidence upon which to build best practices. So you see all these I recommendations, that's for insufficient evidence. And so the CF Foundation supported a project to try and develop an evidence base upon defining best practices. And this was the launch of what we call the STOP program. STOP stands for Standardized Treatment of Pulmonary Exacerbations. Your own Natalie West is a member of our team in trying to design trials. And as we began to think about where we would start, what you try to look for is where the opportunities are. And we focused on duration of therapy. And what you can see here is in the registry, we could look at all of the events treated with IV antibiotics and how long they were treated. And what you see here is, although there's a peak at 14 days and another peak at 21 days, there's an enormous spread. And so it cannot be that everybody got exactly what they needed. And there is this concept that there might be a duration of therapy which is too short and they don't get fully treated and will have another exacerbation in short order. But there also is the risk of treating for too long, that they're not getting any added benefit, but it comes at greater cost and risk. And so the first interventional study we called STOP 2 tried to address this. And although this looks like a complicated diagram, it's pretty straightforward. These are actually two studies in one. So at visit 1, we enrolled people who were being started on IV antibiotics for treatment of a pulmonary exacerbation. We didn't ask specifically why, they just, if the doc had decided they were going to be treated, they started them on antibiotics. It could be inpatient, it might be at home. We then looked at, about a week later, at visit 2, we looked at lung function and we looked at symptoms. How much had they changed from when they were started? And if they had robust changes in that time, we define them as early robust responders. And if they didn't change sufficiently, we call them non-early robust responders. So in those robust responders, we compared 10 days to 14 days of antibiotics. In those non-early robust responders, we compared 14 to 21 days. And in all of them, we looked at visit 3 occurred 2 weeks after completion of the antibiotics. I won't go into telling you why that's the best place to look at, but that's what we chose to do. And so we tested whether 10 was as good as 14, and we tested whether 21 was better than 14. Not because we believed it to be so, but better being to be worth the added treatment. And so when we looked at the study completed, we enrolled nearly 1,000 people. And actually, Johns Hopkins is one of the top performing centers in that study. So what you see in terms of the change in lung function, these are the early robust responders. You see they had a much bigger change in lung function compared to baseline than did the not early robust responders. But I think what you can appreciate is there is no difference between whether they got 10 days or 14 days. In this group, there was no difference if they got 14 or 21 days. So that was really remarkable in terms of those outcomes. And in terms of symptoms, which patients told us was the most important thing, again, there's a difference between the early robust responders from those who are not, but in terms of treatment durations, those numbers were the same. So there are some conclusions we can drive from there. You could say the duration of IV antibiotics is 14 days. Maybe you could go shorter if you've got someone who really had a robust response, but there really is no advantage for longer durations. And so we believe these results should have an immediate impact on clinical care, on decision-making, and certainly will standardize future studies of exacerbation treatment. And we are in the process of designing STOP 3, which would be the next study. But I want to get on to the next thing, and I realized that I did see these slides being shown, and I hope I won't be redundant, but I'm going to take the approach from the research side. So there is an effect of the Trikafta that, as was shown earlier, there was a marked reduction in exacerbations in those on Trikafta. The younger kids, there was no difference. And so obviously, if we're going to be studying exacerbations, well, we've got fewer people having events. That doesn't mean we shouldn't study it, but it might have an impact on how we think about it, how we design those studies. Because we need to look at what is different about these patients having these events to these patients that are continuing to have events, and how might that affect our enrollment in those particular studies. The other question is the effect of COVID, and I know that this slide was also shown, and what basically seeing here is that compared to 2019, which is here in the green, that prior to COVID, we had similar numbers of visits that rapidly went down, not to zero, but almost zero after the pandemic hit, shifting towards these televisits. It has begun to shift back, and what you see now is this sort of hybrid clinic that there are some people being seen in person and others being seen at home. Ignore the tailing off because that's about reporting. But I think the people have found this place, and now what we're going to have to do is how do we know how to best deliver care? We built this center model with this team approach, and now if people are in clinic or not in clinic, how do we effectively deliver what we think is highly valuable in these patients who have benefited from Trikafta or taking advantage of the telemedicine approach, so that we can be comfortable knowing what is the best practice in terms of providing the care. And I want to conclude with just a comment about participation in research. We owe an enormous debt of gratitude to everyone who participates in research. It's a safe bet that everyone I ever meet or talk to has taken a medicine at some point in their life, whether it's a prescription medicine or an over-the-counter medicine. Next time you take it, I want you to think, somebody volunteered for that. And so we owe that gratitude, and we take it very seriously. Doing clinical research is not for everybody. There's various reasons why people participate, but I say a great thank you to all of you who've been part of our trials. And I'll stop there, Peter, and entertain any questions.
Oh, that was great, Patrick. Thank you very much. There were a couple of questions during the chat as you were going along. The first one was, is there any consideration for using Trikafta or other modulators for adults that are carriers that have some symptoms of CF but maybe don't have a diagnosis of cystic fibrosis? They have one mutation, maybe an unknown mutation, this CFTR-related disorder that is sometimes described. What are your thoughts on that?
So this is a tricky area, and there's an ongoing project in Europe of trying to rein in the concept of CFTR-related disorders. Clearly, these are people who have a reduced CFTR activity. How much it's contributing to their symptoms and disease is the other part. But I'm going to take it a step further and say that one should consider whether there's value to using modulators in conditions other than cystic fibrosis. So for example, the potentiator, ivacaftor, has activity against normal CFTR. And so one can begin to ask, well, are there other conditions in which there might be some advantage to using that? There are a number of other conditions that are similar to CF in terms of clinical outcomes, like other cases of bronchiectasis. I can think of the lung transplant population. If there's enhancement of CFTR activity, would that have any benefit for the development of chronic rejection? Because that's generally starts in the small airways. There has been discussion in the transplant community about using modulators in their CF patients who've undergone transplant. On the one hand, they don't necessarily need the triple if we're just looking to potentiate CFTR in the transplanted lung, but the benefit or potential benefit for the other organs like the sinuses and the liver and the pancreas, is that still a value? There was a pro-con debate about that at the North American meeting. There are no studies that I'm aware of in other CFTR related disorders to demonstrate benefit. I can tell you that there is laboratory evidence that in an animal, cigarette smoke inhibits CFTR activity. And if you treat them with ivacaftor, you can restore CFTR activity. So there may well be conditions in which these drugs will provide benefit. I don't think we should use a $300,000 drug to treat our smokers. I think they should just quit smoking. That would be the better strategy. But these are all interesting questions that I think need to be tested, can be tested.
Another question is there any information about CF drugs that could help in COVID?
So the COVID experience is really novel. As you know, the data comes fast and furious. We've been getting weekly updates on the effect of COVID in the CF population, and at least in the early stages, we were feeling a sense of relief that it was not having a drastic effect on our CF population. Some have questioned why. I would argue it's likely because of infection control measures. You've got a population that is accustomed to that language and taking greater precautions. What was seen in the Southern Hemisphere was a reduction in the number of influenza cases, probably because of the isolation and social distancing that took place related to COVID. In every academic center has established a sort of COVID response team to look at all of the therapeutic opportunities that were discussed. I can tell you that we have looked at over 350 study opportunities. Everybody who has a drug that affects any aspect of the inflammatory pathway wanted to have it tested. In general, those were not related to CF products, but there are CF products that people have inquired about. And even something as simple as the hypertonic saline, because in these sick patients in the ICU, airway obstruction is an issue. But in the early stages, hospitals and respiratory therapists were concerned about that it would enhance aerosolization and putting healthcare workers at risk. My bias is that we have improved in our ability to care for these sick patients because we went back to what we did already instead of changing our practice for fear of acquiring COVID and going back to standard approaches to treating these patients. So there's been discussion about whether these products offer any benefit, but there's never been anyone to test it.
And I think just one final question, and that's, is there any research being done for the treatment of aspergillus and fungal infections?
The fungi are a persistent hot topic in the CF space. And in general, what you find in CF is the same thing I learned as a young boy. If you go looking for bugs, you find them. And so you start turning over rocks, you find stuff. If you look and your lab knows how to do the testing, you will find fungi, especially aspergillus, in darn near everybody. And the question then becomes, it's there, what is it doing that's harmful? There's a number of data that show that there's there's low evidence that it's overly harmful. I'm excluding ABPA patients, the allergic patients to aspergillus. And what that is based upon is registry analyses that can't find an association with worse outcomes, and some therapeutic trials that didn't show any benefit. Having said that, that does not mean that it's not causing some problems in some people. It's really about trying to identify how do we know that and who those people are. There are other fungi that are getting a little more interest, like Scedosporum, that people worry about might be a little bit more problematic for people. There were a number of projects that were funded by the CF Foundation this last year to explore further the role of fungi in CF airways disease.
Well, Patrick, I want to thank you for taking the time to talk to us, give us an update on what's going on in research, and to thank you for all your work in really championing drug development. And I'd also echo the thank you to all the participants and people that have been part of the research program at Hopkins and throughout the CF community.